Please start, sir.
Yeah.
We are live.
Yeah. Good evening, doctors. Thank you for joining tonight's discussion on prostate cancer. Regards from Bayer Oncology. Today we have Dr. Krishna Sutanya, sir, Professor, Department of Medical Oncology from MNG Institute of Oncology and Regional Cancer Center. So over to you, sir.
Yeah, thank you, Bayer, and thank you, Sandeep, for this opportunity. And I would invite our today's speakers and panel discussion on MHSPC, Dr. Niharika and Dr. Kishore. I welcome them. And today's the agenda would be how to early intensify the therapy in MHSPC, and what is the recent data on MHSPC? Is it like a triplet or doublet, which is preferred, and what is the the indications for usage of these doublet or triplet? And in that, what is the recommended drug? What is the robust data available for addition of the AR pathway inhibitors in both doublet and triplet? So that would be the agenda for discussion today. And I would like to invite now Kishore. Please take up and go ahead with your the case presentation and as well as MHSPC data.
Yeah. Good evening, sir. Good evening, everyone, and thanks for inviting me. Thanks to Bayer for giving me this opportunity. I'll just share this screen.
Can't hear you. There is a voice break. I think, yeah, now we can hear. Yeah, over to you, Kishore, sir.
Yeah. I'm just trying to share. Are, are you able to see my screen?
Yes, sir, we can see the screen. And
PPT is visible?
no, sir. As of now, we can see the screen. Now it is off, sir. We can't see the screen.
1 minute.
So first of all, open your presentation.
Yeah, now I think it's visible.
Yeah, now it
Yes,
is
sir,
visible,
visible.
sir.
Make it a
And you're
slideshow
audible.
also.
Yeah. Thanks to Chaitanya sir and Bayer for giving me this opportunity. We'll just go in coming 20 minutes. What was the available data in metastatic HSPC until now? It's a just quick review, and we all know any patient whoever detected initially are either locally or local advanced CA prostate, and then they will progress to biochemical failure and then HSPC and then CRPC, and finally most likely they may sometimes, not every time, sometimes they may succumb because of the disease. And this is the first trial data which was published in metastatic HSPC setting. Just look at this. This is the stampede control arm. If you look at the one is failure free survival, and the one is overall survival. We can take it as a standard control data. It's almost failure free survival was in 50% of the people, it was 11 months, and the median overall survival roughly corresponds to 42 months. This is with ADT alone. This is the standard backbone treatment previously for all trials in stage 4 prostate cancer hormone sensitive setting, with a median FFS of 11 months and with a median overall survival of 42 months. Here the journey was started. And then is there anything more we can do for these patients? Yes, later on the remaining trials were came initially with docetaxel and then with novel anti-androgens. And this is the stampede one in there in stampedes. There are so many multiple arms are there. One, they want to see what was the benefit of the radiotherapy. In the above graphs were less than 4 bone metastasis, below was more than or equal to 4 bone metastasis. And we can take it as like it's a low volume or high volume disease. Above graphs for corresponds to the low volume disease, below graphs for corresponds to the high volume disease. Just look at that. In the low volume disease, there is a gap between two curves, control arm and testing arm, whereas in the below curves there was nothing big gap between the two curves. Roughly we can say that there is some failure-free survival advantage with addition of radiotherapy in low volume disease compared to the high volume disease. With respect to overall survival, yes, there is looks like hazard ratio is 0.64. Some benefit is there, but one thing is sure, in high volume disease, not looks like addition of giving RT over and above whatever backbone we are giving may not add much more. But in low volume, yes, there is a benefit. Coming to next, what were the remaining things which came into the picture? First was docetaxel, and then coming to abiraterone, and then coming to the enzalutamide and apalutamide. Now the new molecule was darolutamide. And we'll just go one by one as a rough snapshots and rough summary of the trials. The first one was docetaxel. Two trials are there, almost three trials are there, but mainly Charted and Stampede. These are the two standard trials which we usually most of the times quote. Just look at that high volume and low volume. In low volume, any disturbance is there from my side? Am I audible?
You are audible, sir. Please go ahead.
Yeah, in low volume, if you look into the hazard ratio is almost 1, hardly there is any benefit. And high volume, it's almost 0.6. For me, as per Charted, with docetaxel, there is a clear-cut benefit is there in the high volume compared to the low volume. But in Stampede, yes, even low volume also got benefited from docetaxel. But the magnitude of benefit was more in high volume disease. Just then coming to the latitude, this graph was mainly corresponds to the high risk hormone sensitive prostate cancer. Just look at that. The median was 36 in the control arm. With addition of abiraterone estates, it's almost 53. There is some amount of benefit is there even in high risk also with abiraterone. And but there are some added toxicity. Why? Because always we wants to add prednisolone with abiraterone, even though it's a 5 mg OD, but still there are some increase in rates of toxicity compared to the placebo, especially hypertension and liver toxicity, hypokalemia, and some amount of cardiac disorders. There is a slight more and above ADT. Even still with ADT, there are some cardiac side effects are there, but over and above, there are some with adding abiraterone. Mainly, these are the things which usually happen: hypertension, hepatotoxicity, hypokalemia, and cardiac disorders, and some amount of edema. And later on, the coming to the picture was apalutamide. Just look at that. With all these with all these anti-androgens, the mainly the magnitude of benefit was more in low volume compared to the high volume. And compared to high volume, the magnitude of benefit was more in the low volume. But yes, even still in high volume, the benefit was there. But compared to high volume, the benefit was more pronounced in low volume. Just look at that hazard ratios 0.53 and 0.36. And later on, next drug was which coming to the picture was enzalutamide. This is enzalutamide study. Still, just look into that. Progression-free survival was 0.4 and overall survival was 0.6. There is a clear-cut benefit. Same even with enzalutamide also. The low volume magnitude of benefit was more compared to the high volume. It's almost low volume, the magnitude 0.4. Here, the high volume hazard ratio was 0.8. Looks like these novel anti-androgens looks the magnitude of benefit was more in compared both low volume and high volume, but compared to high volume, the benefit was more in low volume. And now coming to the picture was what we can add over and above standard of care. Until now we have seen ADT, and then we have seen radiation, and then we seen docetaxel, and then novel anti-androgens like abiraterone and enzalutamide and apalutamide. And over and above, is there anything we can do much more for these patients? Yes, two trials were came. One is Peace One, and the one is Arasens. In piece 1, they have tried triplet. It's a 4-arm study. The control arm, they kept it as standard of care. They want to test two things. One is RT and another one is abiraterone over and above standard of care. They kept initially standard of care as ADT, but later on they modified it to ADT plus docetaxel. And in this trial, the catch here would be they have taken only de novo metastatic patients. They haven't taken metachronous metastatic patients. They have taken only de novo, means upfront metastatic patients which were not treated for metastatic disease. Those patients only they have taken. And compared to the Arasens trial, where they have taken synchronous and metachronous patients, they have taken. And just look into that high volume and low volume. In high volume, the hazard ratio was roughly 0.72, whereas in low volume 0.83. For me, looks like the more benefit was drawn in the high volume disease compared to the low volume disease. I think if you want to add abiraterone over and above ADT plus docetaxel, maybe the ideal candidate would be high volume disease compared to the low volume disease. And in the same way, the Arasens, and here only two arms. One is the control arm was same, ADT plus docetaxel. The in testing arm, they have added dorolutamide over and above ADT plus docetaxel. The primary endpoint was overall survival. Secondary endpoints, there are multiple secondary endpoints are there: time to castrate CRPC and time to pain progression, and symptomatic skeletal event-free survival, and time to first symptomatic skeletal event, and time to initiation of subsequent anti-neoplastic therapy, and time to worsening of physical symptoms, and time to initiation of opioid use for more than or equal to 7 days, and safety. We are not going in detail of Arasen study, just will take a snapshot of results. And just look into that, almost 87% of the patients were able to complete 6 cycles of docetaxel. And they have taken all PS1 or PS0, and all are hormone sensitive, that is must inclusion criteria. And candidate should be a ideal and able to tolerate it, both ADT and docetaxel. Mostly this sometimes this may not be an ideal candidate what we used to see daily in the clinic. Maybe 50 to 60% of the people will satisfy this performance status. Some patients may be present in a poor performance status also. But the catch here would be almost 90% of the people are able to complete 6 cycles of docetaxel. And just look into that, the left one was overall population, the right side upper one was high risk patients, and right side lower one was low risk patients. And sometimes we are using the term of low volume and high volume, sometimes we are using the term of low risk and high risk. This high volume and low volume came from charted trial, high risk and low risk came from latitude trial. The definitions are a bit slight different compared to volume and risk stratification, but more or less the biology may be similar, whether it is high volume or high risk, or low volume or low risk. But the definitions are a bit difficult, bit different from each other. Just look at that overall population, the hazard ratio was 0.68. More or less, the drug is giving benefit to the entire population. Now dividing it is high risk and low risk. If you want to see, both groups are getting benefit from the drug. High risk is getting benefit and low risk is also getting benefit. And the secondary endpoints like time to CRPC, time to subsequent anti-neoplastic therapy, and time to pain progression, time to first skeletal related event, more or less everything was looks decently good with adding third molecule compared to over and above docetaxel plus standard of care. And in the same way, PSA response and outcome, this was just have a look at this undetectable PSA at 24 weeks, 36 weeks, 52 weeks, and at in any point of time. You have taken the blue bars was blue bar was quite significant compared to the red one. The blue one was with the triplet, and red one with that orange one with the doublet. At any point of time, you can take like always triplet patients. In triplet patients, undetectable PSA, the number was more compared to the doublet patients. It's obviously expected by adding third drug, maybe the depth of response and duration of response will be more. In the same way, whenever the PSA was detected and PSA was not detected, obviously the people who are in whom the PSA was not detected will do better compared to the patients who are compared to the patients in whom we are able to detect the PSA. They have taken an endpoint of 36 months. In the same way, in high volume metastatic HSPC also, in the same the patients in low volume and high volume, in both undetectable PSA number was more in triplet compared to the doublet. And in the patients who got a undetectable PSA, they are quite long duration, they are disease free. And this is in the low volume disease. Things to consider, things before conclusion. Previously only doublet and then plus or minus RT in low volume, and then in doublet place either chemotherapy or any other androgens and anti-androgens, and in that one is abiraterone or enzalutamide or apalutamide. Most of the times we try to, I think, available those two. Now the third drug was came, darolutamide, and then now we have a option of using triplet also. And these are the things which we usually take into the consideration. Not only single factor when we are deciding the treatment, there are multiple factors: age, comorbidities, and volume of the disease, and risk, and biology, and whether the patient can be able to fit enough to take the treatment or not. And these are multiple factors which will influence us to decide treatment in a given new patient. Thanks from my side. I'm happy to take questions. I think in discussion we can take questions.
Thank you, sir. Chaitanya, sir, are you there?
Sorry, I just have one. Patient which I recently treated with the triplet. He's a 75-year male, hypertensive, diabetic, and he came to me with a back pain, and PSA was 155, prostate biopsy, adenocarcinoma, and Gleason score 7. PET-CT, PSMA PET was done. There are multiple skeletal lesions, and some are outside the axial skeleton, and multiple non-regional lymph nodes are there. As per volume charted definition, he land up in high volume disease, and chemo workup was done, acceptable chemo workup, and the biopsy was sent for MMR and HRR gene panel, and MMR was intact. HRR gene panel, no mutations were detected. P53 mutation was detected, and roughly the diagnosis would be CA prostate, synchronous, high volume HSPC. And initially I'm a bit skeptical whether he will tolerate chemotherapy or not. That's why but in view of is the age was 75, but his performance status was almost zero. His general condition was too good, and age is a just number. That's why I took a chance and I tried triplet, but I'm still skeptical with respect to the chemotoxicity. That's why I kept docetaxel as 2 weekly compared to 3 weekly. And initially I started darolutamide at out of ideally it should be 2 2, but some logistic point of view I started 1 2, and he tolerated very well. Until now he completed docetaxel 7 cycles. Now I shifted to darolutamide 2 2 standard dose. Recently the PSA was done, like I think after 7 cycles the PSA was 0.3, and now we are just try to complete the remaining cycles of docetaxel and try to continue darolutamide, and is doing good as of now. I haven't seen any toxicity as of now. He's doing good. This is one experience which I have with the triplet in almost 75 years patient. Thank you.
Thank you, sir. Chaitanya, sir, are you there? Sir, we can't hear you.
Hello, Chaitanya sir. Sir, can we close this session?
Yeah, I stopped sharing. Madam can share.
Yeah, ma'am, I think there is some disturbances, maybe technical glitch. So thank you, Kishore sir, for your presentation on MHSPC. So now I request Dr. Niharika madam to present the data on RNOte, which is recently approved by DCGA. So Dr. Niharika is, ma'am is a associate professor in the Department of Medical Oncology from Homi Baba Cancer Hospital, Visakhapatnam. Over to you, ma'am.
Uh, Thank you, Sandeep. 1 minute, I'll be sharing the screen. So, can you see my screen? Is the screen visible?
Yes, madam, visible.
Thank you. First, I would like to thank Bayer and Sandeep for giving me this opportunity. Today, I'll be discussing advancing metastatic hormone-sensitive prostate cancer treatment horizons, darlitamide without chemotherapy based on the Aronik pivotal trial. So Dr. Kishore has already shown this, and initially it used to be ADT alone was the backbone. Now there are so many landmark trials which has transformed the practice in metastatic hormone-sensitive prostate cancer. So now the treatment intensification is the standard. But despite these many advances, a large proportion of patients with metastatic hormone-sensitive prostate cancers are progressing to castrate-resistant prostate cancers within approximately 3 years. Though the triplet therapies and doublet therapies are there are many unmet therapeutic needs because of the toxicities. Chemotherapy is unsuitable in many elderly and frail patients, and drug-drug interactions are complicating the managements, and CNS-related adverse events are affecting quality of life. So, for this, there is a Erasmus trial which showed darolutamide plus ADT plus docetaxel, which has demonstrated favorable efficacy and safety compared to ADT plus docetaxel in patients with metastatic hormone-sensitive prostate cancer. Though it has favorable efficacy and safety, but still in many patients, chemotherapy is becoming challenging because of their age or performance status. So this Aronate was designed to evaluate darolutamide plus ADT versus ADT alone to provide a new treatment option for metastatic hormone-sensitive prostate cancer without docetaxel. Coming to Aronate study design, it is a randomized double-labeled placebo-controlled phase 3 study, which was done in 665 patients who were diagnosed with metastatic hormone-sensitive prostate cancer histologically or cytologically confirmed adenocarcinoma of the prostate with ECOG performance status of 0 to 2. They are stratified based on visceral metastasis and prior local therapy. Randomization was done in a 2:1 fashion between the experimental arm, darolutamide 600 mg twice daily along with the ADT, and the control arm, placebo plus ADT. And this study was conducted as a double-blinded till the primary analysis. The primary endpoint was biological progression-free survival, and the key secondary endpoint was overall survival. And other secondary endpoints are time to initiation of subsequent anti-neoplastic therapy, time to castration-resistant prostate cancer, time to PSA progression, and rates of undetectable PSA, time to pain progression, and safety. Other pre-specified endpoints are PFS2, time to skeletal related events, time to deterioration of FACP total, time to first prostate cancer related invasive procedures. After the primary analysis, this was changed to open label trial. All the 100% patients received darolutamide, even placebo patients, and the selected endpoints in this are overall survival and safety. Data cutoff was taken on June 7, 2024, with a median follow-up of darolutamide 25.3 months and placebo group 25 months. Coming to the baseline characteristics, key features are each of performance levels was 0 to 2 in both the groups, and visceral metastasis is noted in the stratified patients, and metastasis at initial diagnosis was seen in nearly 70% of the patients, and high volume disease is seen in nearly 70% in both the groups. And prior local therapy was also similar in both the groups. And Aronate trial was designed in a global fashion. It included 30% of Asian patients with 13.7% Indian patients in the darolutamide group and 14.3% in the placebo group, showing that the strengthened external validity and applicability across populations, including Indian patients. Coming to the primary endpoint, radiological progression-free survival with a hazard ratio of 0.54, there was 46% reduction in the risk of radiological progression or death in the darolutamide plus ADT group compared to placebo plus ADT group. And median radiological progression-free survival was not reached in the darolutamide group. In the placebo, it was 25 months. At 24 months, the progression-free survival rate was 70.3% in the darolutamide group compared to 15.1% in the placebo group, showing the absolute difference of 18%. This has a clinically meaningful and substantially robust benefit. Coming to the subgroups, with high and low volume disease, the benefit was consistent across both the groups and in patients with or without visceral metastasis. Coming to the secondary endpoint, the key secondary endpoint is overall survival. At the time of primary analysis, overall survival data was immature. There were 23.1 events in the darolutamide group, and placebo group there was 26.9 events, showing there is a numerical benefit towards the darolutamide group. Since overall survival is significant, patients will be followed for survival. All remaining placebo patients were offered crossover to darolutamide after the primary analysis. Coming to castration-resistant prostate cancer with the hazard ratio of 0.4, the darolutamide median time to castrate-resistant prostate cancer was not reached in the darolutamide plus ADT group and 13.8 months in the placebo plus ADT, which is shorter. So this shows that there is substantial delay with darolutamide plus ADT group compared to placebo plus ADT group. Coming time to pain progression with hazard ratio of 0.72, darolutamide has shown 28% benefit in the risk reduction for pain progression. The median was not reached in the darolutamide group compared to placebo group. The median was 29.9 months. Delay in the time to pain progression can be of high importance to these patients and have not been demonstrated with other androgen receptor inhibitors to date. Coming to PSA, time to PSA progression, with hazard ratio of 0.31, 69% reduction in the risk of PSA progression is noted in the darolutamide group compared to placebo group. Median time to PSA progression is not reached in the darolutamide, and in the placebo it is 16.8 months. Deep PSA response, that is PSA less than 0.2 nanograms per ml, achieved in 63% of darolutamide patients and significantly lower in the placebo group. This indicates profound androgen receptor pathway suppression. This PSA benefit is seen in both high volume and low volume disease. Coming to subsequent life-prolonging docetaxel, darolutamide group has substantial benefit and durable disease control compared to the placebo group. There is a potential delay in treatment sequencing burden. Coming to incidence of treatment-related adverse events, they were similar in both the darolutamide and placebo group, but the median treatment duration with darolutamide was 24.2 months, and placebo group it was 17.3 months. And the discontinuation of the drug because of the adverse events was less in the darolutamide group compared to the placebo group. Common toxicities which were seen are fatigue, hypertension, falls, and rash. These are the most adverse events which were seen with darolutamide group compared to the placebo group. Darolutamide has estimated median time to resolution in the factor P total score of 5.1 months over the placebo, and it is the first and only androgen receptor inhibitor to demonstrate clinical meaningful delays in pain progression and overall well-being in terms of social or family well-being or functional well-being, and decrease in the urinary. To conclude, darolutamide plus ADT has significantly improved radiological progression-free survival in patients with metastatic hormone-sensitive prostate cancer. Darolutamide has showed a benefit across all secondary endpoints, and it was associated with deep PSA response regardless of the baseline PSA. Darolutamide is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in terms of pain progression, overall well-being, including social or family well-being, functional well-being, and urinary symptoms. Darolutamide also had a favorable safety profile. Based on this, darolutamide plus ADT without docetaxel should become an additional standard of care for metastatic hormone-sensitive prostate cancer. Thank you.
Thank you, ma'am. Ma'am, can we wait for another 2 minutes because I'm just trying to connect with Chaitanya sir. There may be some technical issues sir has been logged out.
Sure.
So give me a minute, ma'am. I'll
Yeah,
check it.
thank you.
Hello. Hi, madam. I think Sar was not able to connect. I think there is some, some connectivity issue is there. I just want to take your opinion, madam. Madam,
Yeah,
are you
Kishore.
there?
Yeah, I'm there.
Yeah. Just two, three clinical questions, just to share your thoughts. Like, what was the like whenever you are chasing in HSPC setting, like how you are choosing triplet versus doublet, madam?
Basically, I'll see few features, whether how is the disease volume, particularly whether it is high volume disease or low volume disease, and whether there are visceral metastasis and symptomatic burden. And coming to patient also, patient performance status is equally important. So I would like to see patient's performance status and comorbidities and whether they will be able to tolerate chemotherapy. If patient is fit and there is high volume and visceral metastases are there, I would like to prefer triplet therapy. If patient is not fit, then I prefer doublet therapy.
Correct. Yeah, absolutely. Same thing. What we used to do in the clinic. Uh, what we used to do in the clinic, based all three factors like disease and patient related factors, and mainly these two, and the drug profile also. These three factors will take into the consideration. Will try to decide the doublet or triplet. Madam, coming to doublet, like what were your thoughts whenever you want to choose a doublet? Like how you usually choose, like abiraterone or what is that, enzalutamide, whichever three molecules are available. I think if patient is fit for docetaxel, I think you always choose triplet. If patient is not fit for triplet, then I think you will choose between these two, either abiraterone or enzalutamide or darolutamide. Like how would you choose usually in the clinic?
Based on all the data, I prefer darolutamide, but problem is many of my patients are not affordable for it.
Correct.
So we had to choose between enzalutamide and abiraterone in such situations.
Correct.
Ideally, my choice will be darolutamide.
Yeah, I think because of less toxicity and tolerability is more, tolerability is better, not more,
Yes.
with darolutamide compared to these two. Am I correct, madam?
Yes.
Yeah, I think with abiraterone, I think we have hypertension and hepatotoxicity, and some hypokalemia and some cardiac issues. With enzalutamide, we have CNS side effects also. I have one patient I just want to share with you with enzalutamide. I have previously I have never seen. I have used in many patients, but recently I have one bad experience with enzalutamide. I just started and patient started used to complain, not seizures per se, but some sort of CNS side effects. And I never experienced such side effects previously with so many patients. That's why I usually went ahead with 160 mg. And then I started tapering, but still symptoms were not resolved. And then I stopped. And but that patient has a bit different disease profile. And once again, I started thinking to start at low dose. Still, the patient used to experience those side effects. And finally, we contributed side effect is mostly because of the drug, and we withhold it. Yeah, I think those side effects may not be there with the darolutamide. With my limited experience, it's a very smooth drug to tolerate it compared to the remaining molecules.
Yes.
And
That is my experience too.
correct, man, correct. And is there any patient profile where you choose only docetaxel as of today? I think
Not much. I
I
prefer
think
either
correct,
ADTL, this androgen receptor inhibitors along with docetaxel.
correct. And in any patients you are giving RT, madam, to the prostate?
Yes, we are giving RT to the prostate once the disease is well controlled. We are still following that.
That is in mainly low volume disease
Yes.
compared to the high volume disease. I think after 3 to 6 months of therapy, and then we'll
Yes.
do a
After
PSMA
6 months
PET
of
scan.
therapy, we are
Next,
doing LRT.
prostatic disease was well controlled and disease was confined to prostate. Then we try to consolidate with RT, especially in low volume. Correct. Anything you wants to add, madam? Like other than this, anything you wants to add or anything you wants to comment it?
No, as such, I have limited experience only with darolutamide, just
Great.
2 to 3 patients, but all of them did very well in terms of safety. But unfortunately, I could not give longer in those patients because of the progression. But nearly an year or so, we have managed.
That is all are triplet, madam, or anybody you have given
No,
is tablet?
majority both one is doublet and one is triplet, but the triplet the patient could not tolerate after 3 to 4 cycles, so we had to stop and continue with doublet.
Okay.
And now planning to start a triplet, so would like to see how it works, means how the patient tolerates.
Okay. What was the maximum years you usually keep? Not years, as I previously told, it's a number only. Most
Hmm.
likely performance status and general condition. Like,
Yes.
what was the age of your triplet patient, madam? Roughly
Around 70 years.
17. Good. Fair, madam. I think it's done. Any questions? I would like to take any questions. We are happy to take any questions.
No, I think
Questions or comments?
we have discussed.
Yeah.
what-
Yeah. Sandeep? Sandeep? Anybody from Bayer?
Yes, sir, I'm here. I think ma'am will also discuss a couple of points there. Then we can close the session. Maybe another comments. Ma'am, are you there?
Yeah, I'm there. Dr. Kishore, how you see in your practice the financial status, means how many patients will be affordable for darolutamide based on your experience?
Yeah, as of today, the main problem is with affordability, ma'am. Previously, also you are pointed out that the main problem was affordability. Recently, also I have experienced one patient. I counseled them, but they're not willing only because of the affordability. Or else I am so keen on to start doublet with darolutamide, not triplet. I have decided I don't want to give triplet to that patient. I have decided to give doublet, but still I opted for darolutamide, but they are not affordable. That is the thing. Affordability is the main thing which will pull us back.
How was your experience in progression with either darolutamide or with any other molecules in the prostate cancer as such
Means
after
see,
first time?
yes, ma'am. Darolutamide, my experience is only limited. That's why it's very difficult for me to comment it out. And coming to abiraterone or enzalutamide, yes, as per trials, so yeah, we have good number of patients, and some 2 years PFS, some 3 years PFS. It's mainly depend upon the biology of the disease. The patients with good biology, they will have good PFS compared to the bad biology, and these factors will come into the play: volume of the disease, Gleason score. These are the things which will decide the biology mainly, how the patient may behave. Yes, post progression with these novel antigens, I try to keep it as chemotherapy, not once again anti-androgen. Even trials also have shown the PFS was not so good after one anti-androgen, after another anti-androgen. My choice would be docetaxel. If I use docetaxel in the first line, then the second choice would be obviously, but the PFS is not that much maybe great.
Do you do BRCA in all the prostate patients?
Correct. Yeah, ma'am. Previously I used to do HRR panel, not only BRCA, HRR panel in all the patients, not at the front line. We used to do at least in CRPC setting. But in recent ASCO 2025 Amplitude phase 3 data was out. It's in the HSPC frontline setting. That's why I am a bit interested towards that data also. Looks promising. A long-term follow-up has yet to come, but data looks promising. The days are very short. we are going to use PARP inhibitors in the front line with HRR gene mutations. That's why nowadays I am doing frontline. Even recently, what I told, like I just shared one patient details. There also I have done in the frontline HRR that came negative.
So are patients willing to do HRR in the front line because it is also again cost?
Yes. That it's not so easy to do at the front line. Whatever investigations initially we are doing for the treatment per se, like PSMA, PET scan, and biopsy, and PSA, and whatever remaining workup, blood workup, and cardiac workup, everything for that only patients will just exhaust it. But yes, motivated and educated patients are willing to do, and usually we will not wait for the reports. We'll start something before getting the reports. Yes, it's depend upon the patient to patient. Yes, 100% all patients will not ready to do the everything at the front line.
Yeah. How do you see the patients with skeletal mets and patients with like nodal mets? Do you find any difference in their disease in the treatment profile, or do you find any difference in them?
Yeah, if you look into the trials, nobody is mentioned or nobody is given importance to the non-regional lymph nodes. These visceral mets, they are all not in visceral mets. They have, it's not a non-regional lymph node actually, but all these non-regional lymph nodes patients also will come as stage 4 CA prostate. And if you take it as like some 10 intra abdominal retroperitoneal lymph nodes and 5 mediastinal lymph nodes and 2 supraclavicular lymph node and one single bone mat, he will also come as a low risk or low volume, frankly per se. But I don't think so these patients may behave as a patient CA prostate with single L4 mets without all these non-regional lymph nodes. I feel maybe that is, I don't know, whatever with existing data, maybe not adding non-regional lymph nodes in the risk stratification, maybe one thing which I usually felt. But yes, these patients also will do a bit worse compared to the single bone met with non-regional lymph nodes and single bone mets with multiple non-regional lymph nodes. Both patients are a bit different, what I usually feel.
So do you prefer darolutamide doublet or triplet, or what do you prefer in such patients?
It's,
Do you
it's,
prefer darolutamide or
yeah,
what do you
my
prefer?
my take would be, if I felt patient is fit enough to take chemotherapy, that's all, doublet. Triplet, if patient is not fit enough to take chemotherapy, doublet. And then doublet, once again the choices, obviously I try to prefer darolutamide. Previously I'm a bit skeptical as there is no data, but now we have data to support it, and data also showing promising, and more or less on doing same as with other molecules.
Yeah, with Aronate, it has even showed that high volume and low volume doublet is also better. So this, as it comes under low volume, maybe doublet. I prefer doublet in such
Correct.
situations.
Correct.
So how means how many patients in percentage of patients will tolerate chemotherapy in your regular practice?
Yes, maybe hardly. Most of the times until now I have given mainly doublets only. Recently only I have started using triplet, maybe 2 to 3 patients, that's all I have given until now triplet. Most of means data also came recently, maybe 2 3 years, and that's why the more experience is with the doublet compared to the triplet. But yes, now started using triplet also.
Yeah. In regularly we are using triplet, but not with darolutamide. Mainly, as
Laboratory.
many are financial issues, we are giving a Ebritron docetaxel in many of the patients. Do you would like to discuss anything else, or
No, ma'am, that's all.
Sandeep?
Yeah, ma'am. I think sir is there, but I can see, but I can't see that sir is. Sir, are you there, Chaitanya sir? Yeah, I think sir, there is some technical issue. Sir may not be available, so it's okay, sir. I think we can conclude the session with this. I can let me check the chat box if you have any questions. Give me a minute, sir. So I don't see any questions in the chat box. So thank you, Dr. Kishore sir, and thank you, Dr. Niharika. Ma'am, so for your beautiful presentation on MHSPC. So with this, we can conclude the session. Thank you. Thank you all. Good night. We can conclude this.
Thank
Thank
you.
you, thank you, thank you.
Yeah, operator, please close the event. Thank you.
Hello, Sandeep sir, can we close this meeting?
Yes, please close the event. Thank you.
Okay, thank you, sir.